usual and unusual tremor. We will continue as we finished in this morning. So we will discuss clinical problems, and I will a little say 5 years. These are my declarations, and there's nothing which interferes with this lecture. I just wanted to start by discussing briefly the philosophy of this new classification. Like, for example, for distant temporal onset and evolution, past medical history, family history, alcohol and drug sensitivity of the tremor syndrome, tremor characteristics, associated signs. Here comes, for example, clear neurologic signs like Parkinsonism or dystonia. Is basically already belonging to axis 2, which is etiology. The separation of these two things was done purposefully because we have some pretty typical clinical features, but on the other hand, they are non-idiopathic Parkinsonian syndromes, or you can develop it just because somebody took neuroleptics. So there are, it's good to separate these different conditions on a very early stage. Of what is. Tremor is defined according to the activation, and that can either be during rest or during action. And then you can have a kinetic, a postural, or an strong, and then you develop a tremor. And the kinetic tremors, that is most differently used in different papers. So simple kinetic tremor means just a movement like this. When this is getting trembling, then this is where you take a pencil, you write, and all of a sudden tremor develops. Then postural tremor is separated into position dependent and independent, which is important particularly for the whole field of task-specific tremors. And this is important for the separation, and we will go into this. Okay, based on these characteristics which are shown here in axis 1, we can define a number of tremor syndromes. And that is shown in this slide here: static tremors, tremors with additional signs, and others. Here we have the dystonic tremors, Parkinsonism-associated tremors, intention. And now we will just look at cases. And I want you to make your diagnosis and your interpretation. Have a look at this lady first. So this lady, I don't know if you can see it. This lady had tremor during the resting condition. And she also had tremor during the postural condition if she had the hands longer put forward, but in between there was a break. What is
it's a re-emergent tremor?
Re-emerging tremor, yes. It's called re-emerging tremor, but the term re-emerging tremor is correct. It is a tremor that is present during rest. It stops when you move the hand, and it comes back. But the important thing is not the re-mind, that the important thing is really the suppression before a patient moves. So it's a tremor at rest, not during voluntary action. You can see it even better here. And it's blocked during goal-directed movements. It's called tremor type 1. Let's look at this lady. You can just comment. So now what do we see? Oh, I'm really sorry. video lives from this lady has a very severe tremor during action and any kind of movement. She has some dystonia, that's true. Yes, she's very akinetic. So-called type 2 Parkinsonian tremor. It is a tremor that occurs during rest and during posture and action. And usually during posture and action, the tremor has a higher frequency. And that is a tremor form that needs to be separated to some. It is assumed that these two tremors do have a different pathophysiology. When it comes to treatment, what would you do with them? I mean, just in general, Parkinsonian tremor, what is the best treatment of classical Parkinsonian tremor? Dopa therapy, absolutely. It's a dopa-sensitive symptom, but not in all. What do you do then? If you are at already 600 milligrams of levodopa in an early onset Parkinson's disease who only suffers from tremor. Huh? What I do. I mean, I always just want to know, is it really a dopa-sensitive tremor? And sometimes I have patients where I go up to 1,000 milligrams. But it's not a permanent treatment then, yeah?
What's your experience about this in
patients is then to use an anticholinergic. We have some different brands in Germany. You know, if the patient is a little bit older, I tend to, and really suffering from tremor. I mean, that is the key. You have to certainly be very careful with that. And make sure that that you follow the rules for blood testing. Again, a case, and now he is really having a bad tremor. It's a classical postural tremor, which also is. I mean, first of all, this is type 3 tremor, as we call it. And what do you do with them? Don't care about tremor. That's the first 1 or 2 months in the early phase, and you should tell the patient the tremor may not react. But then after 2 months, you have to.
That's why sometimes we see in MSA myoclonic
Yes,
tremor.
yes, that's a different form of tremor. That's a myoclonic tremor, which is more irregular than this type, which was very regular even if you couldn't see it. So that's something different. Usually it's not. And what do we do then? That is a case where you can try, for example, propranolol. This sometimes works. Even primidone sometimes works. You have to test it out because there's no overall recognized paper. And it has been clearly shown that this tremor is usually not responding to dopaminergics, but sometimes to propranolol. Okay. Yeah?
Peut-être souvent aussi on peut utiliser les neuroleptiques. Est-ce que souvent ça donne de l'effet? Gabapentin, même la dépakine aussi. Est-ce que souvent ça donne de l'effet?
I have only experience with gabapentin in this type of tremor, and this is not so favorable. Similar as with essential tremor. The gabapentin trials were all pretty mixed. And very just as an overview, this is about the separation of Parkinsonian tremors that is useful for treatment considerations. Also, this type 2 sometimes responds to propranolol. So take it, and certainly, as always, the question is, what is it? So you see, he has tremor also during these movements. He should have done a little bit slower, than you could have seen it better. What is it? To assess the patient, but this patient has no neuropathy. He has also head tremor, but that can also happen in neuropathic tremor. I think that's the age. And this is the other side of the spectrum. I mean, this is already a pretty bad tremor, one must say, suffering from a very severe essential tremor, and that's about the spectrum that you have. In young people, it can be even much less, so just a little bit like this. That's simply, I mean, this is the most common tremor by far, and they have an abnormal tandem gait, which means 10 steps, one misstep during 10 steps is already abnormal. And this lady is much worse during gait. She cannot. Okay. And the definition of essential tremor has been renewed. Before we had isolated tremor syndrome of bilateral upper limb action tremor. So with the emphasis on bilateral, that has always been exclude, all these enhanced physiological tremors. With or without tremor in other locations may be present, but only if you have also hand tremor. So if it's a pure head tremor, it's a focal tremor. And absence of other neurological signs, certainly. And then we have made a new category. We do have a number of patients which do not fulfill this definition. In the essential tremor research field, we are looking for genes and for whatever, and we are constantly unsuccessful. And so we said, if there is a chance, I think very nice with reality. So particularly for essential tremor, the picture on essential tremor has changed. In the past, we always thought this is one disease, and we simply mix it up with a few other diseases. Now we have changed perspective. We say causes behind which need to be detected. Probably the most important one is, in terms of numbers, is the aging-related tremor. I will not go into too much detail, but we can discuss if it's ET+, because that is probably a clinical indicator to help us to sort these patients out. I will show you later other cases. So what is this, for example? Is this ET or is this ET+? So this is not a resting position. What is special to this movement? It is irregular, it's jerky. It's a classical jerky tremor that you can see here. And this is a plus. This makes it plus from the very beginning. I know the cause in this particular case, at the clinical symptoms in detail, and make a diagnosis if it fits or not. So you see she really suffers a little bit from her tremor. I won't go into details. What about this lady here? Oh no. I mean, this is a regular movement. This is particularly critical when it comes to tremor. But this movement, which looks like quite the same as before, is obviously very different. So it's very jerky. It's clearly abnormal, and so she has a unilateral problem. She has a history of 15 years with that condition, and this is the kind of patient that are out in the community. You always see them. And in the future, we will term them ET+. Can you open the sound? I think you can't hear it. This lady has a severe voice tremor. she is still understandable. So we can understand what she says, but if you listen to her, you have trouble. I mean, you know, you get tired because, yeah. So it's the voice has always break.